Welcome, everybody. This is our first edition of student presentations. And today, Laura Higgins, who's a second-year student at CCNM, is going to be presenting on post-concussion syndrome. I'm Dr. Batson. I'm the head of neurotrauma education for the neurotrauma evidence synthesis training. So we'll get started today, and let's have some fun. So the disclaimer is here for everybody. Even though we're going to be talking about assessment, diagnosis, and treatment, this shouldn't be used for that purpose without further training and education. So the basic idea is, even though some of you are future doctors or current doctors, let's make sure that you receive some additional in-person clinical hands-on training before you go out and start using some of the things that are taught in here. And obviously, those that are seeking personal medical advice should consult with a licensed physician. And the images are appropriately cited, and they're used for educational purposes only, under fair use as well. So let's get going. And you know what? I can't get, there we go. Let me see if we got, okay. So Laura, take it away.
So here we have a definition of traumatic brain injury. I've highlighted the things that you would look for, that there's a loss of or decreased level of consciousness. This is after a traumatic event that either caused a structural injury or the physiological disruption of the brain. Both parts we'll look at later. You could have a loss of memory for events immediately before or after the injury. You could have an alteration in mental state at the time of injury. And there could also be neurological deficits. You can see some examples there on print, as well as potentially an intracranial lesion. And that would be what they'd be looking for on imaging. Slide. So this sort of just demonstrates the different motions that the brain goes through in different types of injuries. So not only could you be struck in the head causing a brain injury, but your head could strike something, have a direct impact that way. As typical with like a whiplash car accident, there could be a sudden acceleration or deceleration. And basically, you can see the red parts at the front and back of the brain there, where you're creating that contusion at the front or the back as a result of the brain moving within the cerebral spinal fluid and making contact and creating that effect. Or even a lot of the information that we get is from the VOD, the veteran information from the Department of Defense. And so blast injury is also indicated. Slide. Here we're looking at a more formal classification, dividing it into severity. So mild, moderate, and severe. We are looking in this presentation at mild. And I just want to emphasize that mild is a word as a classification, but the downstream effects of a mild concussion or traumatic brain injury are huge. So mild is way too mild of a word, although let's look at it specifically. The imaging is most likely normal. If there was any loss of consciousness, could be nothing up to about 30 minutes. That would then, over 30 minutes, then move up into moderate. There might be an alteration of consciousness or mental state up to the first 24 hours. You could have some post-traumatic amnesia. So all of those things keep it in the mild category. The Glasgow Coma Scale is one of the scales that are used to evaluate severity. And we'll look at that in a later slide, how you calculate the score. A score of 13 to 15 is considered mild on the Glasgow Coma Scale, as well as in this concussion classification. But there are many scales to diagnose, and we'll go over a few more of those. Slide. If you have a mild traumatic brain injury, it could be complicated or uncomplicated. And the definition basically means that in imaging, if you can actually see some sort of difference due to the injury and intracranial abnormality, that would then bump it up from being uncomplicated to complicated. So this is the Glasgow Coma Scale. There's a link that takes you directly to the information. There are videos there. You can see the categories that they're checking. How are they able to open their eyes? Can they verbally respond? Are there motor responses? And depending on the grade in each of these categories, you create that score. So the higher the score, the less severe. And that's why that 13 to 15 is considered mild. This is something that you could, all of these slides have references that I would recommend that if any one slide or topic interests you, that you jump off and look at in further detail. So we'll go to the next slide and see what else we have. So now going specifically from the mild traumatic brain injury into what is a syndrome, once you start to have a set of symptoms or conditions that tend to occur together, whether that's a disease or just an increased chance of developing something, they classify that as a syndrome. Let's go to the next slide. Here we have a beautiful graphic, which both Dr. Batson and I love, demonstrating just what is happening with the brain upon an impact. Post-concussive syndrome then describes a constellation of symptoms that commonly occur after an MTBI. And they're roughly grouped into categories of physical symptoms, cognitive, behavioral, and emotional. Let's go to the next slide. This is the timeline. About 90% of people presenting with traumatic brain injuries, mild traumatic injuries, they will resolve spontaneously within 7 to 10 days. However, we go from the acute phase to the subacute phase. If after that 10-day period, we still have people having symptoms, that's when it transitions from being classified as a traumatic brain injury into a post-concussive syndrome at the subacute level. More people will resolve. However, if after 3 months we're still looking at this satellite of symptoms, we can call that chronic. And after a year, if some of those symptoms are still persisting, it then becomes a persistent post-concussive syndrome. And sadly, we included at the far right here the potential that this just becomes a permanent satellite of symptoms that never resolve. Slide. So prevalence-wise, again, I have to say this with a caveat. What we have evidence of as reported is that 42 million people per year worldwide suffer from new mild traumatic brain injuries. Over 1.7 million mild TBIs are reported per year in the US. And I'm going to pause on that for a second to say that I didn't include it in these slides, but there are some studies that indicate that only 1 in 9 MTBIs are actually being reported. So if you thought 1.7 million was a big number, now multiply that by 9, and that might be the actual number. I saw a lot of work being done on the CDC to improve their surveillance systems in order to capture more accurately the actual presentation of traumatic brain injuries. Over 450,000 children, as a subset of that 1.7 million, visit emergency departments each year for traumatic brain injury, of which 90%, almost 90% of them are classified as mild. And here I mention again the severe underreporting. Let's get to the next slide. In terms of prevalence, I think if you had no research at all, you might assume that head injuries are more prevalent in males due to riskier behavior. And also in youth, 50% are between the ages of 15 and 34 years old. However, older aged people having the brain injuries are more likely to develop a post-concussive syndrome. As a demographic, it's a higher prevalence in athletes, veterans, and contact sports. The thing I found really interesting when I was looking at this is that there's a lot of studies that have been done looking at, well, what was the condition of the brain and the human before they had a concussion? And these things that we're looking at here, especially towards the bottom, if they've had a concussion before, they're more likely to develop the PCS. If they already have a diagnosis of anxiety, ADHD, migraine, or learning disability, if they already had noise sensitivity, those types of things tend to crop up as being something that might indicate that they would be more likely to develop PCS. The first two there, the length of loss of consciousness and the delayed five-word memory, those are tests that are done in the moment when they present. And depending on the results of that, that might indicate whether they might downstream end up with PCS. But there's also protective factors. Happy to know higher education is one of them. Mild symptoms might be one of them. No extracranial symptoms. And also, it's really good to know that youthful neuroplasticity is protecting some of those 50% to present in the youth category, that their brain has the potential to heal. Slide. So thinking back to that slide where we talked about the percentage of people, I just translated that percentage into actual numbers. So if 1.7 million presented, 90% of them resolved within 7 to 10 days. Now we go to the subacute. About 50% of the people who did not resolve at about 1 month will still be experiencing symptoms. So that's about 85,000 people. And again, remember, this is annually. So every year this is happening again and again, that 85,000 more people after a month post-concussion are developing PCS. Yes, PCS. Going into the chronic phase, now we finally get to the persistent phase. Still about 15% are having this condition. So that's representing 13,000 people. And these are statistics from the US. So of course we can magnify that worldwide. But we're here at the end of the year almost, and 13,000 people are going into the next year, adding on year after year to people experiencing PCS. Slide. This is another thing that I think I intuitively knew, but until I did the research and looked at it, and this graphic in particular, you have your immediate primary injury, and over hours to days, usually specifically within the first 48 hours, the delayed injuries start to begin. And that we have a few slides that we can show you that type of injury. But all those times when they said, "Oh, you've hit your head. We've got to watch you for, don't go to sleep or don't do this." I mean, there's a lot of different advice that comes out. But this is why, because the secondary injuries are the things that are going to develop into those neurocognitive issues. And we'll go to the next slide, which will also get into more detail. Again, this is a jumping off slide. What is happening in that secondary injury is a neurometabolic cascade. You can see, just without even knowing a lot about what these numbers mean, if we're starting at a baseline and we're looking at potassium, glutamate, glucose, and calcium, this is at impact. And the cerebral blood flow, which is bringing all the nutrients to the brain, decreases at the time of impact. So when you're most injured, you're having the least nutrition to help heal. We can look at the slide on the right, and it indicates the flow of what's happening, the ionic flux between the calcium, things that are actually dying, the axonal injury, where the force, and if you imagine that graphic with the brain matter shuffling in the skull, axons are either tearing or stretching, and the neurotransmission as a result of that is affected. So other projects that'll get presented later will go into more detail about this, and we also have a video coming up. I think is the next slide. This is, we don't need to go into this, but Dr. Batson and I had some fun talking about, what is the actual history of treating the concussions. And we can go back to the medieval times and what the doctors were doing there. We can look at the Renaissance, what's different 100 years ago. This particular slide sort of groups everything together into what's happening, what changes, specifically focused on the glia. The term reactive astrogliosis. But what I want to emphasize about the history is that the papers I was reading that came out in 2013 said, we think this is what's going on, and we want to explore this further, and we need better imaging in order to figure out what's going on. And now we're about 10 years later, and we're really entering into that era of new types of imaging that are finally able to give us more definite answers about the secondary effect of concussion. Let's get to the next slide. We'll play this video.
Welcome to 2-Minute Neuroscience, where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss concussions. A concussion is a type of mild traumatic brain injury that occurs when rapid movement of the head or an impact to the head causes the brain to move within the skull, potentially stretching axons and damaging cell membranes of neurons. When neuronal membranes are disrupted, it can cause the dysregulated flow of ions into and out of the cell, as well as the increased release of excitatory neurotransmitters like glutamate, which leads to further disruptions in ionic balance and a general inhibition of neuronal activity. Sodium-potassium pumps work frantically to restore balance, but this causes depletion of energy stores and an energy crisis that's compounded by lower than normal levels of blood flow. Additionally, the increased glutamate activity prompts excess calcium to enter cells. The high calcium levels can disrupt the function of mitochondria, amplifying the energy crisis. The decreased energy availability may last for days to a week or more and impact cognition. The trauma and subsequent effects can also damage the structural integrity of neurons and glia, further disrupting brain function. These structural and biochemical changes are associated with the symptoms of a concussion, which include but aren't limited to headaches, confusion, memory loss, and dizziness. After a concussion, patients may also experience an increased susceptibility to another injury, and repeated concussions have been linked to longer-lasting effects on brain function. In some cases, patients who have experienced repeated concussions may begin, often years after the repetitive trauma, to display symptoms of early-onset dementia, mood disturbances, and Parkinsonian symptoms. The resultant condition, known as chronic traumatic encephalopathy, has also been linked to the appearance of neurofibrillary tangles and amyloid plaques, which are typically seen in neurodegenerative diseases like Alzheimer's disease.
So looking as clinicians, the subjective criteria that the patient will report will revolve around these areas: somatic issues, behavioral and sleep issues, cognitive issues, emotional issues. And so that's why it's important to remember all of the categories. And if we look at the Rivermead post-concussion symptom questionnaire, you can see that there's quite on the left, quite a list that you can go through and ask about each of these things and score it. But there's also the RPQ3, which just focuses on the first three. So headaches, feelings of dizziness, nausea, and or vomiting. And quite often that's where the pharmacological solutions come in as well. Let's get rid of this headache. I don't want to throw up. Or what can you give me? That type of thing. The study on the right looks at it using a different way of clustering things. And this particular study showed these were the groups and clusters of symptoms that patients reported within the first few weeks. But then they actually did the study 10 years later. And a lot of these symptoms are still there, but they cluster in different ways. And that particular study, I think the focus was they were trying to see, well, how does it change? And how can we maybe improve the downstream effects, understanding what becomes more prevalent after you've been living with it for a while. So another jumping off point. Slide. ICD-10 criteria. Again, we see headache, dizziness, but let's look at fatigue, insomnia, concentration difficulty, and interestingly, the intolerance to stress, heavy emotions, and alcohol, because I do believe that a lot of the recommendation comes down to try and avoid that in your life while you're recovering. And you need 3 or more to make this criteria. I believe the link here can take you to a paper that gives a lot of detail about what qualifies in order to categorize it as ICD-10. Next slide. Now looking at the DSM-4, just to know that this was actually just kind of a sub-note in that edition. It was never a formal diagnosis. It was in the DSM-4. They changed the language about it and did not include it like this in the DSM-5. The other issue with the DSM-4, the controversy over it, is that this apathy, personality changes, need to persist for 3 months or longer. So information about the length of time and persistence is changing as well. Slide. Way too much information for a slide. This is to let you know that there are all of these other tests in addition to the Rivermead and the criteria that we just talked about. In particular, I want to note that for most of these, there's also a child version of it. So they are differentiating between the version of adults and the version for children, and advantages and disadvantages. So let's go to the next slide. So sport has kind of led the way in patient education. And obviously, when you get paid millions of dollars to play sport, there's an incentive to help your athletes recover quickly. So that's part of why they're leading the way in a lot of this. But the consensus is that you don't just go to the emergency, you don't just go to your MD and get a solution. Each of the sequelae present differently, and you may need to go to an array of practitioners to help you with each sphere of symptoms. And if you need psychological support for your emotions, and you need sleep support, all those different things, there are a lot of practitioners that can get involved in this. We mentioned a little bit about the pain management. That's a whole other lecture. I believe Dr. Batson has an expert coming in to talk about that. But one of the takeaways is that resting longer has not been demonstrated to improve the outcome. There's a certain amount of rest you need to have for the first 24 to 48 hours. And after that, there's a gradated return to activity that proves with evidence that that is a better way to do it than to just drop out for weeks at a time to recover, which was part of the, 50 years ago. It was like, take a week off and rest. That's not the advice anymore.
So I'm going to just kind of summarize and expand upon some of the things that Laura has already presented and kind of anchor things through repetition and elaboration. So, we're going to use, there's different ways to assess post-concussion symptoms. And we want to keep in mind a syndrome is a cluster of symptoms, as Laura mentioned, that co-occur together in a predictable pattern. And not all individuals will have all post-concussion symptoms. And that's why the criteria does not require that you have all 16 of these symptoms that are in the River Mead. As Laura mentioned, the River Mead is also divided into two. So you have the RPQ3, which is the first 3 symptoms, and then you have the RPQ13, which is the next 13. And then the conglomeration of those is 16 questions. So generally, clinically, we use this as a screening instrument when somebody has had a known history of concussion and they present to your clinic. And that could happen shortly after the concussion, depending on your type of practice, or it could happen a year later or more in the persistent, prolonged phase. And sometimes we'll get patients who have been 4 or 5 years out and they still have some symptoms. The tool on the right is another instrument that's commonly used. It's called the Sport Concussion Assessment Tool, or SCAT, and it's been through many different versions. So we're now on the SCAT 6, and the SCAT is a larger paradigm for assessing concussion that's not just limited to the questions here. So there's specific types of physical examination techniques and so forth that are part of the SCAT 6, and that's another area that most certainly you can investigate on your own. But they're very, very similar between these two questionnaires. You'll notice that on the RPQ, it says feelings of dizziness, whereas on the Sports Concussion Assessment Tool, it mentions balance problems. Those usually co-occur together. So when you have dizziness, oftentimes you have impaired balance as well. The addition here that's important on the SCAT 6 is you'll see drowsiness. So you see fatigue or low energy on both, but drowsiness generally refers to excessive daytime sleepiness, what we call hypersomnia. And hypersomnia can happen for a number of reasons. It can happen due to simply disrupted sleep, which can be sometimes due to pain if you've got a co-occurring whiplash or other polytrauma or peripheral injuries. But the disrupted sleep can also be biochemical, as you have the neurometabolic cascade involves an increase in the neurotransmitter glutamate, which is the most prolific neurotransmitter in the brain. And glutamate is an excitatory neurotransmitter, so it really makes the brain more active, and people will say, oh yeah, my brain feels like it's on fire and I can't stop thinking, and I'm hypersensitive to sensory input, whether it's light or sound or anything else in their environment. So for different reasons, sleep can be disrupted. There is a condition that we'll learn about later that can occur, including after mild TBI, called post-traumatic narcolepsy, and that's due to damage to the hypothalamus, which is a structure that secretes a neurotransmitter called hypocretin or orexin that keeps you awake. So as you get deeper into managing concussions, sometimes you need to exclude post-traumatic narcolepsy, which is done through a referral to a sleep medicine physician. So otherwise, you'll see mostly symptoms are similar. You'll see the addition of nervousness and anxiety in the SCAT, and you don't see that in the River Mead. But if you learn to take a good clinical history, I still personally just use the River Mead, and I know what questions I need to ask in order to expand my history of present illness when I'm interviewing someone that's had a concussion. So either one of these instruments are fine when you're assessing somebody with a history of concussion. I want to also emphasize that these are, a post-concussion syndrome diagnosis is a descriptive diagnosis. And what do we mean by that? Well, you'll notice that everything here is other than vomiting is subjective. meaning you're not going you're not going to observe it. You might observe some behavioral manifestations. You might be able to see if somebody's more irritable or impatient, or they act out, or they're angry. But for the most part, these are things that someone tells you. So they fall in the subjective realm. And the subjective is a beginning point and not an end point. And so the post-concussion syndrome diagnosis is a starting point. It's not, oh, you have this and you're done. And so in the next slide, we're gonna look deeper into how we would approach someone who's had a concussion and what that might involve in terms of working up the different areas that are problematic for the individual. So you'll notice in the upper left-hand corner here, this is more in the acute setting, or if somebody comes in, the first week, you need to look for red flags. This is not going to be relevant if somebody comes in a year later and they've had a concussion. So as you're taking the HPI, history of present illness, if somebody's had a recent concussion, then it's required as a clinician that you screen for red flags. And if red flags are present, that's an immediate referral to the emergency room. If there are no red flags, or if you're dealing with the patient in the chronic phase, you're going to simply move straight into PCS screening. And again, you can use the RPQ, the SCAT-6, or other questionnaires. Once you've understood the symptoms that are manifest, in my facility, we use a lot of other questionnaires in order to quantify things that are going on, and also to track patients longitudinally over time to see if they're getting better. So this is a whole set of questionnaires that we can look at later on that are highly compatible with the RPQ, and will basically allow you to expand the findings that you see in the RPQ. A good physical examination is necessary when you're assessing post-concussion symptoms. These exams are what we would call bedside neurological exams, or gross neurological exams. There are advanced ways of testing different functions using physiologic instrumentation. Dr. Burns does a lot of that in his clinic, and that's an entirely different lecture. But this is a foundational or introductory lecture. And so we want to do a very good general neurological exam. For those of you who are medical students, you'll be learning physical exam techniques. And then there are some specific TBI exams that are done, and always a good cervical examination, particularly if there's been a whiplash injury, to look at the contribution of the cervical component. Dr. Singh, who's the director of the Seattle Seawolves professional rugby team, and a physical medicine and rehab doctor, is going to be on October 4th, and he's going to cover post-traumatic headaches, and he's going to also talk about cervicogenic headaches and cervical contributions to the perpetuation of post-concussion syndrome. But the TBI specific exams are to be learned. That's really something that needs to happen, where you go to clinic and you shadow and you learn to do these particular types of tests. There's sometimes a loss of smell that can occur with mild traumatic brain injury and more severe brain injuries, and there are standardized ways of assessing smell as well. And most importantly, you need to learn the proper technique with somebody that's experienced, and then also understanding the limitation of different physical exam tests, sensitivity, specificity, and so forth. Once you've completed all of this, you're now in a better position to understand what type of referrals need to be made in this setting. And you can see there are many different medical specialties that can be involved in further assessment of post-concussion symptoms. And each one of these is, at some point, we'll have a specialist from each one of these areas. You can see physical medicine and rehab. Dr. Singh will be on in a couple weeks, and he'll be focusing again on post-traumatic headaches. But the physical medicine and rehab physicians are oftentimes a good place to start. In fact, in my experience, they oftentimes have more to offer than neurology. But specific disciplines will be there to manage different issues that have happened subsequent to the concussion. Neurology is often there to manage post-traumatic headaches. Same with physical medicine and rehabilitation medicine. Neurosurgery is very, very rare in the mild TBI setting. Sometimes there can be an occult cerebral spinal fluid leak that's detected over time, and that needs to be, there's an imaging technique called CT cysternography that's used to detect that, and occasionally a neurosurgical repair might be necessary, but that's very, very rare. Brain imaging is not part of the PCS diagnostic process. It's a clinical diagnosis. However, the brain imaging may be done in the post-acute phase if there's concern that something is going on anatomically when a CT scan has failed to detect that in the emergency department, or oftentimes CT scans are not run in the emergency department, or people don't even go to the emergency department. So there may be follow-up imaging. Neuro-otology is a sub-branch of ear, nose, throat, and then audiology is often done in tandem with that. And neuro-otology helps us to evaluate when there's dizziness and balance impairment. Neuro-otology is sort of the gold standard discipline that is going to help handle these patients. Sometimes there can be anatomical damage to the inner ear. When there's concussion, you also can concuss the inner ear. There's a pressure wave that comes out the internal auditory canal and shakes or concusses the inner ear structures, and those can get damaged. Oftentimes there's a recovery, but sometimes it becomes persistent in about 10 to 15% of individuals that'll have ongoing dizziness and balance impairment. We're going to have one of the top neuro-otologists in the country, who's also a base of skull surgeon, on October 18th, Dr. Giannoli, and he's going to be talking about everything connected to post-traumatic dizziness and balance impairment from a neuro-otological perspective. Neuro-optometry, I think Melinda's going to be presenting on the visual and ocular motor sequelae of concussion. Neuro-optometry is the discipline that helps us to better understand what's going on with visual changes and ocular motor, meaning how the eyes work together efficiently to achieve visual tasks, and then the field of vision therapy, which can help with rehabilitation. Neuroendocrinology is my area and my area of research, and so we showed recently in our data that 18% of individuals that have chronic post-concussion symptoms at 1 year or greater after a mild TBI go on to develop growth hormone deficiency, adult onset growth hormone deficiency. We just presented that research at the Endocrine Society this year. Neuropsychology helps us to use standardized cognitive testing to look at cognitive deficits. Those are compared against age, sex normed, and educational background normative data. And it can also be used to track people over time to see if they're improving. There are other objective cognitive tests that can be used. We now have computerized cognitive testing, which can be used. Dr. Burns uses that in his clinic. I do as well. That can be repeated more frequently, and it's less intensive than 4 or 5 hours of neuropsychological testing. However, the sort of classic gold standard is a neuropsychologist that specializes in cognitive assessment. Neurorehabilitation, there are different types of neurorehabilitation techniques. There are areas that sort of formal that are part of neuro rehab centers. Dr. Burns does a lot of neuro rehab using advanced techniques as well. And at some point we'll have him come on and do a lecture on his facility and how they engage in neuro rehabilitation. Occupational therapy is often there to help with various types of rehabilitation. Sometimes you'll see occupational therapists doing visual rehab and vestibular rehab as well. Physical therapy has an important role both for vestibular rehab, some vision rehabilitation, and then for orthopedic rehab, particularly when there's cervical injury as well. Psychiatry is there to help us out with the neurocognitive and neuropsychiatric sequelae, oftentimes from a pharmaceutical management standpoint. when individuals are not resolving, or they sometimes may need temporary, in other cases, permanent pharmaceutical management to help with some of the neuropsychiatric problems. For example, I have patients, particularly men, that have had concussions and end up developing anger problems, and it's affecting their relationships and that type of thing. And sometimes, for the sake of family systems, a little pharmaceutical management can be helpful to kind of manage those symptoms. We'll talk about in other lectures pharmaceutical management of cognitive symptoms. Sometimes stimulant therapy will be indicated. So all of that can happen through psychiatry or psychiatric type prescribing. Speech and language pathology is there to help out, particularly with cognitive rehabilitation in the concussion setting. And sometimes there are other speech and language issues that need to be mitigated as well. Sleep medicine is there to help with various types of insomnia or other sleep disorders that are not improving over time after concussion, including evaluating for post-traumatic narcolepsy when there's chronic excessive daytime sleepiness. And then vocational rehab is really about getting people back to work. There's actually a large burden of disability that's associated with chronic post-concussion syndrome. And it's either people not being able to return to work or not being able to work at their prior capacity. So they may have to do part-time work, or they may lose their job. It's not infrequent that we see patients come in and they're struggling at work, and then eventually they get fired. This is quite common. So vocational rehab helps to assess their current level of capacity and sometimes transition into a different type of job. So in my practice, I've had people that were high-level executives that can no longer do their job, and they end up having to do something else. So vocational rehab is the discipline that helps us to sort of assess that. So this is a broad overview of a clinician-based management of post-concussion syndrome. And again, you're there if you're going to be in primary care, which many of you will be. You're there to help manage this and to help make sure that people get to the right place, to see the right types of specialists for the type of rehabilitation they need that's specific to their problems, but also to find other diagnoses that may have objective basis behind them. For example, do they have neuroendocrine dysfunction with hormonal deficits? That's objective. That can be seen through specific lab testing and advanced endocrine diagnostic testing. We can image the internal auditory canal and the inner ear to see if there are lesions or dehiscences. We can do objective tests of eye movements to be able to see if there's binocular vision deficits and so forth. So there are a number of other disciplines that can help us provide objective diagnostic information that supplements the subjective syndromic diagnosis and further validates why people are experiencing these things, and also helps to guide treatment. So this is a basic overview, and we can now do Q&A and open things up in just a sec. So I want to let's see what's next. Well, not quite yet. Got a couple more slides. This is something to explore for those of you that are part of NEST, which I think all of you here today are part of NEST. You're learning to do systematic reviews, and there are a lot of questions we still have. So I put this here for the researchers who might be interested in exploring different types of therapies. And so have a look at these, and if any of you are interested in doing a systematic review in one of these areas, just talk with either Dr. Goldenberg, Josh, or myself. And if we have enough interest from other researchers, then we can most certainly do a systematic review on one or more of these particular topics. This is from Brent Massell. Brent's a colleague of mine at University of Texas Medical Branch, where I'm a research collaborator. Brent is probably one of the oldest, or Dr. Massell more formally, one of the oldest brain injury neurologists in the country. And this is a fantastic paper that was published in 2010 that I encourage everyone to read. And it's really helping us to look at traumatic brain injury as a disease process and not an event. And particularly with mild traumatic brain injury, as Laura mentioned, the results of so-called mild traumatic brain injuries are far from mild in many cases. And in fact, the CDC, Centers for Disease Control and Prevention, in 2003 had a report to Congress, and they said it's really important that we differentiate between TBI incident and TBI outcome. And they were very clear that mild should not be conflated with outcome. And so, unfortunately, due to that language, we have a group of individuals that have been called the invisible minority, because the concussive brain injury generally does not have gross anatomical findings on neuroimaging. And for many years, this particular population has been misunderstood. Oftentimes, particularly in the legal setting where I work, they're told that they have conversion disorder or a somatoform disorder. And I'll give you an example. I had a young lady that began vomiting chronically within 2 days of her concussion. And for 4 years, she vomited 10 to 20 times a day, losing 40 pounds. She was diagnosed with a conversion disorder and obliterated in the medical legal setting. And then when I saw her, it was very clear that she had a very severe vestibular disorder with probable damage to her inner ears. And Dr. Giannoli was able to diagnose that with 3 different lesions in her inner ears. And within a week of using a medicine to lower her intracranial pressure, her vomiting went away. So she was diagnosed with conversion disorder, which was an incorrect diagnosis. So keep in mind this mild TBI population is often invisible, and they're not understood. There's not enough knowledge amongst providers. When you finish this neurotrauma program, you will be within the 0.01% of medical providers that has what I would consider to be a thorough and proper education in a traumatic brain injury. And hopefully many of you will go on, if you stay in this program, to be emissaries to educate other providers. I want to quickly go back to this slide and look at the referral network here. And one of the things I didn't emphasize is you need to know whether to refer. You need to know when to refer, meaning in the course of evolution of symptoms, and to whom. And the basic idea is not every specialist is created equal. And so you really want to find medical specialists that are subspecializing in brain injury, and ideally who are researchers and are published. And Dr. Giannoli will talk about, for example, within the neuro-otology field, how there's probably only 5 neuro-otologists in the country that are really doing comprehensive testing at his level out of 300. And so just because you send somebody to a specialist doesn't mean they're going to do an optimal job. We see that in endocrinology quite frequently. General endocrinologists have missed a number of diagnoses that we picked up at my clinic where we're specialized. So if you go into concussion management, you're going to want to get to learn in your particular area who are the specialists that have further subspecialization focus in traumatic brain injury. And you just kind of learn through the process who those providers are. So discussion, Q&A. Let's open things up for the group.
I have a couple of questions. So I noticed in the symptoms, it didn't include symptoms that I've experienced, and maybe they're just named differently. But like with my concussion, I've experienced vibrations, like my brain just like, it's almost like the nerves in my brain were like vibrate. And then also it's almost like ocean waves go through my head. I haven't experienced these for a few months now, but over this last year, those were like very strong symptoms that I had experienced.
Well, when we talk about dizziness, it's a very general term. And so if you do a little preceptoring in neuro-otology, you'll learn that things like waves going through your head can be considered a form of dizziness. We can have classical vertigo where the room is spinning, but there's also, you can be rocking on a boat. You can have sort of waves of pressure and fluctuations in the head. And so all of that can broadly fit under dizziness and would raise the suspicion of a vestibular disorder.
Somebody can have, if and I'll give this example to people, you're stressed out, you're anxious, and we put you on a beach, and now you're fine. And you're fine because the level of stressor to the system is not challenging your physiological capacity to deal with it. So people can be symptomatically feeling fine, and sometimes they're not even actually very conscious of they're not very aware of what's going on, but they're functionally impaired. And then those are the ones that you see, especially in athletes. They get hit again, and then they really have problems because they get weak. Their bolts in their wheels get a little loose. They're not up to spec, and then they run into bigger problems.
Yeah, one of the things that Dr. Burns is highlighting, which is very important, is that symptom manifestation can be intermittent and environment dependent. And we often see this with return to work. Somebody will be off for work for 2 or 3 months. They'll get clearance. They say, I'm feeling better. And right when they go back to work, many of their symptoms come back. And that's simply due to sort of, stress load or allostatic load or whatever the requirements are. Oftentimes, for example, if they've got convergence insufficiency, which is the most common binocular vision disorder, and we're doing a systematic review on that right now with some of you, then, they may not have been reading on a computer screen for 2 or 3 months. And when they go back to work and they've got to be on a screen for 8 hours and the convergence insufficiency is present and not mitigated, then they start to get headaches and many of the other symptoms, cognitive fatigue and so forth, and they're not able to function. So most certainly, as Dr. Burns has highlighted, the relationship between the altered brain function and the environment is very, very important to consider. So there's been debate in the whiplash setting, whether is this just a whiplash or did they concuss? And some of the advanced imaging has been able to help us validate, yes, they're concussing and there's actually damage to the brain and it's not just cervical. Although that's an ongoing debate for different reasons, and including influence by the medical legal environment, which with brain injury, you've got a large number of concussions per year that have open litigation. And so there's almost no way to talk about concussion without interfacing with the law. And that's something that we would do in an advanced training, talk about that for clinicians that are seeing patients that then have open litigation. And that's, again, an advanced topic, but it's important to understand that some of the medical literature and some of the debate is actually influenced through litigation, which drives compensation in an adversarial environment.
Yeah, I have a couple questions. One of them I think is a pretty big topic that maybe would need its own lecture. When you're talking about how in the past concussions they would often suggest to rest for like 2 weeks, but now they say like 24 to 48 hours, it just had me thinking so many questions about the physiology of healing. Obviously, there's so many different brain structures, and they probably each have their own unique physiology, like patterns that they go through as they're healing, but just like the timing of that and why like such a short time, like is it because we want more blood flow to the brain? Just like a whole bunch of questions about healing physiology.
Yeah, I mean, I think that's a great student project. I mean, I can tell you what I know, but within every area, the goal here is to have a team where we expand our knowledge base. I'm familiar with a lot of literature on that topic, but that's not my area of research. I wouldn't say that I'm an expert on that. Part of it most certainly has to do with blood flow. Exercise has also been shown to increase brain-derived neurotrophic factor, which can help with repair as well. And so you'll see some literature on exercise and BDNF as well. And again, there's a researcher out there that's just doing research on BDNF and exercise in the concussion setting, doing a PhD somewhere. So each one of these is a really interesting topic.
I did have another question, and this might take another lecture as well. But I noticed in the treatments that one, LDN wasn't mentioned. And also, I actually just recently, because LDN didn't end up working for me, and that's kind of a whole other discussion, but I've just started doing this thing called EE systems technology, which deals with scalar waves. I don't know if you've heard of that at all.
There's all sorts of new things. I mean, this is just an example. And if you look at pharmaceuticals, you'll see at the very end it says etc. And what that means is LDN is included, low dose naltrexone. That is a pharmaceutical. And so there are many other pharmaceuticals that aren't mentioned on here. So within this is just a starting point. This is not meant to be comprehensive by any means here. And of course, none of the botanical medicines are mentioned. Lion's mane is being researched, which is a mushroom, for example. It's got a lot of research going into lion's mane. So all of these areas, I mean, the goal of our research group is to build, we've got 49 participants and 12 trainees in the neurotrauma program. You know, the goal over time is to have a bit of an army of researchers that are really interested that can all contribute to this. And somebody might go out and say, I want to do a systematic review on botanical medicines for concussion sequelae and so forth. And there's many different areas, and we cannot do it alone. It's a community, right? It's not a single person or expert that knows everything. We know that as researchers. We can only develop a small amount of knowledge in a lifetime. And so each one of us is going to try to develop knowledge that contributes to a broader community that's cohesive and integrated and understands each other. And that's really the bigger vision of what we're trying to accomplish with NEST. So whatever you have a passion for, go for it. I mean, a lot of it, you'll always find that research is much easier when you're really passionate. So,
and also just to the point of the function aspect and the age thing, that is all about, there's even differences within, say, children and 15-year-olds versus 18 or 20-year-olds. The greater the myelination, the greater the path, the greater the stability of systems, the more resilient that individual is, which then, of course, that decays with age. So
there are discrete issues that need to be identified and treated. For example, with vestibular disorders, you'll find that within the chronic phase, about 1 in 3 may actually need a surgical remediation because there's an anatomical lesion or dehiscence, and you need to detect that and you need to mitigate that. And those are individuals, for example, who aren't responding to vestibular rehabilitation or anything else that you're doing, or they revert back after a course of neurorehab. So we've had patients that undergo neurorehab and they get an initial benefit, but later on they regress or relapse. And so same thing in my field, neuroendocrinology. If you've got a chronic hormonal deficit, you're not going back, you need to treat that. And so we want to identify discrete problems that can be treated. And then we move into a model where we say, okay, the brain is a holistic organ, as Dr. Burns is referring to.
When I talk to patients, I'll talk about brain like a family dynamics. You can have a bunch of people that are very healthy, and then one individual, say, becomes an alcoholic, and then you start to see breakdown elsewhere, right? So it's a integrated systems, and diascosis is just secondary and tertiary remote problems that aren't where that initial trauma is. Concussion is the event. That's not what we're treating. We're treating the sequelae. We're treating the progressive pathophysiology.
I'm wondering if we're going to get a lecture about the downstream dementia and Parkinson's.
We will, yeah. And in fact, Dr. Goldenberg and I completed a white paper on that, a systematic review on concussion and dementia that eventually, hopefully, we're going to move into a larger systematic review and publish. But yes, we're also going to be, within the advanced neuroimaging paradigm, we have something called the connectome. And the connectome is basically helps us to understand interconnections in the brain, different hubs of neuronal activity and how they connect to other sites in the brain. And there's a whole model referred to as disconnectome, which is essentially how those communication networks are disrupted after a traumatic brain injury. And we now have ways of mapping that. This is advanced neuroimaging. This is generally done in different paradigms, including magnetic resonance imaging. functional magnetic resonance imaging, and other types of advanced neuroimaging techniques where we can actually map out what we call connectomics and disconnectomics. And that can help to better explain objectively some of the things that Dr. Burns is referring to. So
Amazing.
we'll have a lecture on that at some point. But people need to get some basic foundations in neuroanatomy and other things before we jump into advanced topics. But we'll get there. Yeah.
Good.
Well, thank you, everybody. Wonderful contributions from the entire team.